So it is an absolute honor to introduce Dr. Arleen Brown, who is a professor of medicine in the Division of General Internal Medicine and Health Services Research here at UCLA. She also serves as the chief of GIM&HSR at Olive View-UCLA Medical Center. Dr. Brown's research focuses on improving health outcomes, enhancing healthcare quality, reducing disparities for adults with chronic conditions such as diabetes, cardiovascular disease, and stroke. She's been the principal investigator on studies improving diabetes care for older adults and minority patients, and improving stroke outcomes, and understanding the clinical, socioeconomic, and health system influences on chronic disease management in under-resourced communities. She is currently the principal investigator on several projects, including a study to improve cardiovascular outcomes among persons with a history of trauma who are living with HIV and AIDS, research to reduce health disparities in blood pressure control for patients in Los Angeles County's safety net, and studies to mitigate disparities in COVID-19. Dr. Brown also co-directs the Community Engagement and Research Program for the UCLA CTSI. And in this role, she works with teams of community and university partners to ensure that community and research priorities align, promote research in community settings, and facilitate the exchange of knowledge, expertise between all stakeholders. Importantly, in the last year, Dr. Brown has also joined the multiple principal investigator leadership of our CTSI overall. And to me, this really acknowledges the critically important role that community partnered scholarship in under-resourced communities means in terms of our overall research enterprise at UCLA. And Dr. Brown, along with her colleague, Dr. Norris, have truly led the charge of this agenda for our university. You heard Dr. Jones mention the Community Engagement Alliance Program against COVID disparities. Well, in 2020, Dr. Brown was selected to lead the California site of this National SEAL initiative. The statewide Share, Trust, Organize partner, the COVID California Alliance Stop COVID-19 effort includes 11 universities and their networks of community partners. In this role, she's working to ensure the integrity of COVID-19 clinical trial studies and standards to protect for the protection of voluntary participants while enhancing diversity and inclusion of participation in COVID-19 vaccine, prevention, and therapeutic studies. What you might not know about Dr. Brown is she was in the first cohort of our RCMAR program, one of our very first pilot investigators. And we are so proud of all of her accomplishments and are so happy that we get to take a tiny bit of credit for all of her amazing success. So it is a privilege and an honor for me to introduce Dr. Brown to you.
Thank you very much, Carol. Can you guys hear me? I can't see anybody for some reason, the way the screen is set up.
Yes.
So
I can hear you.
Great. And you can see my screen?
Yep.
All right. So the one thing I'm going to say is Anais may have to step in when we're going to try to do, we have an embedded video. If it doesn't work, she will run it from her computer. But I want to thank you all for inviting me here to speak today. I will honestly say that RCMAR was really pivotal for me in getting my start. You know, after many attempts at K Awards and various grants, it was so nice to have success to get a RCMAR Pilot Award. And I can honestly say that, Sid, you may not remember this, but we had a dinner where you were so encouraging and so helpful as I was thinking about applying for the Beeson Award, which I subsequently got. So you, along with Carol and Keith and so many others on this webinar, played a really important role in my career. And I also I'm delighted to follow you and also to follow Dr. Jones, who has been incredibly supportive and a font of wisdom and support whenever I reach out to her. So I am going to talk today about some of the work that I've done that really leveraged my original RCMAR pilot, which was to understand community level factors that influenced chronic disease disparities. And I subsequently have done work in community engagement. And what I want to talk about today is some of the work we've done around community engagement to address COVID-19 disparities, but also to think critically about using these strategies in times that are in non-pandemic times to think about other types of conditions and the ways that we might work collaboratively with communities to address those issues. So I have no disclosures, and I want to start off, because we often do this at the end, by acknowledging the many, many, many people, including several fellow RCMAR alumni, Ali Casillas, Yalba Castellon, and anyone else I forgot. Also want to thank Dr. Norris, the newly minted NAM member, who has been a partner in crime and a collaborator for many years. We also want to thank the NIH and the CTSA and the California Government Operations Division for their support of this work. So what I'm going to cover today is really sort of do a brief overview of COVID-19 disparities in California and take you back to about a year ago. And we want to discuss community engagement as a strategy to understand COVID-19 vaccine hesitancy, deliberation, and uptake in diverse communities, and discuss some of the initiatives that were built out from the projects we worked on to mitigate racial, ethnic, and socioeconomic disparities in COVID-19 vaccination in multi-ethnic communities across the state. So right now, California is doing pretty well compared to the rest of the nation in COVID vaccinations. But I think figures like this sometimes hide underlying disparities. So we know that there are substantial disparities across the state. The death rate for Latinos is 19% higher than statewide. The case rate for Pacific Islanders is 43% higher than statewide. Death rate for African Americans is 14% higher. And the case rate for communities with low median income is 33% higher. So there are true disparities even in California. This is just a slide that highlights a strategy the California Department of Public Health uses to assess disparities using geographic means. So they look at the most disadvantaged areas, and what they found is the areas with the highest rates of disadvantage are 18 percentage points behind the highest ranking areas in getting vaccinated. So again, I want to take you back to summer and fall of 2020, where we were faced with a lot of misinformation, disinformation, lack of understanding about COVID. And what you see here are some of the headlines from various reports, that many Black and Latino adults lacked confidence that that vaccine development process is actually going to take their needs into account. This is issues around public concern about moving too fast with the COVID vaccine approval process. And we see that it was pretty high for everybody. And we saw that Latinos, African Americans, and Republicans were more likely to be hesitant about getting the COVID-19 vaccine for so many reasons. And we heard a lot of myths. COVID-19 couldn't happen to me. Masks are unhealthy. Youth aren't at risk for COVID-19. It'll be no worse than the seasonal flu. Wealthy elites started COVID-19 for profit. Natural immunity is best. The body can protect itself. And vitamin C is an effective prevention, and you can put hydroxychloroquine or ivermectin or any of a number of other remedies to replace vitamin C with those. Also notions about vaccines altering your DNA, 5G mobile phones, faked results, nanosensors will be placed in you to monitor your location. And sometimes we would sort of be mystified by this, but what we were learning is that it was real. And so we wanted to learn more about this. I also want to take you back to when they were first doing these trials, the COVID-19 trials, and this is the Moderna trial. What you see on the left is the US population. And what you see on the right is the early results from the COVID trials. So you had 60% white in the US population as a whole, but 85% of the participants in the trial up to late July were white. And, this led to many questions about how do you address vaccine hesitancy about participation in COVID-19 vaccine trials and therapeutic trials. So this actually this question arose from a consultation that we had in the Community Engagement and Research Program from Dr. Rafi Landovitz and Judy Currier. And they asked us, how can we, as part of the large trial network, how can we in the LA County area ensure representation, particularly in the UCLA COVID-19 vaccine trials? And the second half of their request was, and by the way, the trial is scheduled to start in a month. And so we actually sat down with them and built out a plan for this, which was the COVID-19 trial panel. And in order to do this, we applied very standard principles of community engagement, planning and preparation, though we didn't have a lot of time for that, inclusion and demographic diversity, so adequate representation, collaboration and shared purpose, openness and learning, transparency and trust, impact and action, having a shared vision of what you want to accomplish, and sustained engagement and participatory culture. So we wanted to partner with investigators and with community members who were known entities and build on those relationships. And so what we did for this is we built out a COVID community panel that was a collaboration between the UCLA CTSI, both the Community Engagement Corps, but also the Clinical Translational Research Center. Several of the clinical trial sites, although the UCLA trial was the one who came to us and they were an AstraZeneca trial, Lundquist Institute at Harbor was working on a trial, the Vine Street clinics had trials running, and so they all came together as part of this collaborative. And then most importantly, we brought together community stakeholders from a range of institutions, organizations, and communities who represented the racial, ethnic, and socioeconomic diversity of Los Angeles County. And we used a deliberative community engagement process, or DCE. This is qualitative research. It's a method that's designed to obtain opinions from lay individuals on complex topics with which they may be unfamiliar, but whose insights are needed because they actually are representative of the communities at highest risk. And so the goals of the panel were laid out just like this. And this is a slide that we actually shared with the panel. Short term, we asked them to help us ensure that the LA County COVID-19 vaccine trial participants represented the diversity of individuals at risk across LA County. And long term, we said once a vaccine is available for wider use, we asked them to advise and consult on vaccine acceptability and concerns. And we also defined for them what community expertise meant to us. So we wanted their perspectives on cultural factors and community norms. We wanted the questions that they had themselves or that they had been hearing and the concerns that the community may have about the vaccine development process and vaccines. And then we asked them to help us frame language, messaging, and communication strategies in order to resonate more effectively with the community. So this sort of just highlights how we did this. So we had a pretty rapid implementation timeline, so about 6 weeks. So we were consulted. We obtained recommendations from the many community leaders who have worked with us over the years. And among the first people we went to were Laura Trejo, who you know well, and Aziza Lucas-Wright, Norma Ntume, and many others. And we held, within 6 weeks, we had our first community consultation panel by Zoom. And what we asked them for was 8 weeks of participation and 2 hours a week. The meetings were scheduled around work, so they were late in the day, generally around 4 o'clock. And they received compensation for this intensive and rapid participation in the process. So about $200 an hour for, on average, about an hour and a half or 2 hours a week. And we sometimes gave them homework. We also developed introductory material, so a clinical trial briefing book, which you see here, a website with resources, news, and video that we updated regularly. And then we took an approach that every week we'd have a brief information session followed by a question and answer and then structured discussion. And it was really important that it not just be coming from the community engagement team, but we also brought to the table investigators and clinicians who were involved in the trials or who were involved in providing care for people at risk for or with COVID. So here's just to summarize some of the recommendations that we got from the group. They really focused on sort of two big areas. The first was increasing trust in the process. So they asked us to enhance transparency. They wanted to know where the trials were and who ran them. Were they academic sites? Were they private sites? And what was the difference between these two types of sites? They also they insisted that we have trusted messages. They wanted clear information and access to resources about COVID-19, the vaccine trial process, and the vaccines themselves. They also identified for us trusted sources in their communities to provide clear information and made recommendations about how to reach those groups and who to partner with. And then they wanted recruitment and outreach for diverse communities. They recommended multi-ethnic media and venues for trusted communication and discussed ways to tailor approaches and methods, face-to-face versus visual, written, or social media approaches. They also really stressed the importance of enhancing the accessibility of the trials. So they asked us they were very focused on providing transportation for trial participants. And I'll tell you, one of the outcomes from that was that we were able to identify resources to make sure that any participant who needed transportation got it. And that was both for routine visits and sick day visits. They were very focused on healthcare for uninsured participants, particularly those who might have an adverse reaction or a COVID-related illness. And we actually really had long discussions and provided detailed information about participant coverage for adverse reactions through the trial. And I would say I learned a lot through this process. I think my colleague, Dr. Landovitz, learned a lot through this process because these were things that often weren't discussed openly. They wanted increased trial sites in minority communities and recommended community clinics and mobile trial sites. And in some cases, this wasn't possible just because of the time frame. But what we saw over time is that there was a trial site that developed at Charles Drew University. And then there were, not in LA, but in other states, we saw mobile trial sites being used, and actually other parts of California. The last thing that they focused on in this area was really thinking about cultural competence and customer service is what it was referred to as. So they felt that participants should be welcomed, asked their gender pronouns, shown the restrooms, given food and drink, and be thanked. And they really felt that it was important to be welcoming because otherwise they knew that members of the community were not going to come or not going to come back. And I want to just highlight for you the difference between the rest of the country and the LA trials. You see here on the far right is the overall LA County population. We didn't quite hit the percentage for Latinos, but we vastly outpaced the rest of the country in Latino, African American, Asian, Pacific Islander, and multiracial participation in the trials. And so I think that was one, and we can't take full responsibility for that, but I think we contributed to this process of really examining these questions early on. The other thing that I think is important to note is in that middle figure is the final enrollment for the COVID, the Moderna study, where they actually used some of these strategies at a national level to increase their the minority participation. So one of the things that came up time and again was really thinking about vaccine hesitancy. So during these discussions, there was a lot of talk about, well, even if you get people to participate in the trial, that's only the first step. How do you get people to think about the vaccine and to be willing to take the vaccine when it is available? And this was right before the first vaccines were approved. So several members of our study team worked on a project that was recently published in JAMA Network Open. It was led by Savannah Carson. And Dr. Carson led a team that included Dr. Castellón Lopez and Dr. Ale Casillas, who are both former RCMAR scholars, as well as Dr. Norris, the head of our CTSI, and myself. And this is the framework for this project was really to try to understand how community members understood barriers and facilitators to COVID-19 vaccine readiness. We wanted to inform the public health initiatives that were ongoing to enhance acceptability of the vaccine. And so what we did is we had 13 two-hour focus groups and asked the participants to contribute and reflect both as individuals and as experts from their own communities. We identified groups, racial ethnic groups that face the highest burden of COVID-19 and related comorbidities. So Latinos, Filipinos, African Americans, Pacific Islanders, and Native Americans or American Indians. And a majority of the participants resided in high poverty areas or were essential workers. And several themes emerged in two big areas. So misinformation, disinformation, and concerns was very important. So one Latino participant said, things sound crazy, but they're understandable. People don't trust the vaccine because they think it's going to genetically alter their body in some way, like they'll become sterile or have some kind of implanted chip that carries along 5G antennas. These chain emails and Facebook Messenger and Viber Messenger about it's not a pandemic, how to cure it with lemon salt water. My concern is that my family are getting all of this bad information from the Philippines and then not listening to our doctors over here. And this was a sentiment that reverberated in many communities where you had first generation communities in particular, where you had relatives, close relatives in Latin America, Philippines, in the West Indies, and people were concerned that they were going to be getting bad information that was going to be hard to counter because no one was looking for it. An African-American participant said, the neighborhood leaders, they're all saying no, they think that COVID is a hoax, that it's not real. The government, the city, the state, they don't trust them. No one's coming around to address health issues or anything with them. So they're like, why should we care about jumping in line, getting a vaccine when we're being ignored? We've always been ignored. And then finally, a Pacific Islander participant said there's certainly that general feeling among indigenous peoples that a lot of times research hasn't been with the benefit of these people in mind. In fact, it's almost the opposite. There were also big questions, however, about equity. So accessibility, affordability, and representation. A Latino participant said, we hope we get the same vaccine that the healthcare staff are getting. An American Indian individual said, our incarcerated community members, elders, the foster care system, we can't forget about them. And another Latino participant said, what phase are the undocumented in? And then finally, a Filipino participant said, Filipinos can get lost in the system because of the language barriers and just not knowing how things work. So we had several big takeaways from this work. One was that vaccine hesitancy, and I should really put that in quotes, is a complex, multifaceted concept that encompasses deliberation, accessibility, and acceptability. That it was really important to reduce structural barriers in parallel with vaccine outreach and engagement. The importance of collaborating with, investing in, and empowering trusted community leaders to share information and provide navigation support, and the need for representation and data transparency for all high risk groups so that you're more effectively able to communicate the vaccine effectiveness by different strata: race, ethnicity, age, chronic disease. Also a desire to dispel misinformation from social media in the US and abroad to support informed decision-making. And then finally, recognizing and addressing upfront that mistrust is based on both historic and contemporary mistreatment. Showing empathy, understanding, and respect to the communities was critical. So while doing this work, we were actually actively developing outreach materials. And so we asked for we developed materials that address the misconceptions as well as the information gaps, that highlighted the diversity in clinical trials, and really tried to engage in broad dissemination of materials and lessons learned from the focus groups, from our community partner groups, and from our COVID community panel. And so what you see here is an example of a project that we use, a product that we developed, which is a timeline of mRNA technology. There was a lot of skittishness around this technology being new, and just sharing with people that this was available, that this technology predated cell phones, and that there were people of color involved in the development of the vaccine. We developed a COVID policy brief that we shared with state leaders and policymakers locally and nationally. And the types of things that we highlighted were, is the vaccine safe for people like me? This was a frequently asked questions sheet. And then how many people from different racial and ethnic groups were part of the clinical trials? We also talked about weighing the risks versus the benefits of the vaccine. So looking at infection versus vaccination, and really giving people visual aids for thinking about, that for helping them with decision-making. I want to highlight a little bit of the work that we did with the seal that was mentioned. It was already described by Dr. Jones and Dr. Mangione. But I really want to thank the many collaborators. We have 11 academic institutions and over 75 community partners. And the goals of this project were to increase knowledge, decrease disinformation and misinformation, enhance diverse inclusion in the COVID trials, and increased uptake of vaccines and therapeutics, particularly across high-risk communities in California. And we have every academic health center across the state, and including several of the resource centers from the RCMIs for minority institutions. And we used bidirectional knowledge exchange, co-development of culturally tailored community relevant strategies, sustainable practices that was informed by the community. And then we have been working to evaluate the effectiveness of these different strategies. So this just gives you a broad overview of what the projects look like. Rather than try to be monolithic and say we're going to have one project for the entire state, given the diversity in the state, we asked each site to partner with local community-based organizations and really figure out the strategies that work best for them, and then really try to provide the infrastructure to support collaboration across the sites. And so many groups did engage in trust education and outreach, community health workers, health fairs, town halls, using the visual arts, qualitative research, capacity building, ethnic media outreach, community surveys and needs assessments, clinical trial community engagement with studios or community advisory boards. And then we worked with CHIS, the California Health Interview Survey, to add questions to their statewide survey. And we highlighted many different populations across the state. And this is just an example of some of the strategies we used. We did Latino media in English and Spanish. The Pacific Islander group, there was a very impressive presentation or a health fair at a Samoan church that brought in a huge number of people. Worked with American Indian and Native American groups around disparities, worked with policymakers and leaders in the African American community. Again, Latino media outreach around vaccines for children. All told, there were over 300 town halls and community events, more than 50 community health workers received training on COVID, 125 plus news features. There were 13 collaborations with COVID vaccine clinical trials, many focus groups, many policy briefs, and we have a few academic publications in the works. This actually, I think, got the attention of the state, who reached out to us with a large initiative to promote vaccine registration. And the goal of the Get Out the Vaccine work was to reduce structural barriers to COVID-19 vaccine registration in areas with low vaccine rates and high COVID morbidity and mortality. And so we, and this is led by Dr. Norris and Alana Trout at the state level, and several groups who have done work on political campaigns, but now we're sort of using these strategies within the community to really influence public health. We partnered with these CBOs, hired unemployed or underemployed local residents as canvassers, and they worked to register people for the vaccine. The strategies were both door-to-door canvassing, text messaging, and phone calls. And then all the canvassers received training on COVID-19 vaccines from the clinicians and public health folks in our group, including Lisa Mansfield, Ali Casillas, and Yelba Castellon, and many others. We also, a lot of these teams provided other resources, connecting people to social services like rental relief, addressing food insecurity, addressing unemployment. And they did this very independently. And the canvasser training included both COVID-19 and information about vaccines and therapeutics, but also strategies for responding to dis and misinformation, strategies for providing information on accessible resources. And this is just a list of some of the groups. Many of you know many of these groups: Esperanza Community Housing Foundation, Black Women for Wellness, CD Tech, Watts Labor Community Action Committee. And I just want to highlight briefly one group, some of the strategies that were used in one group that we worked with closely. So we learned a lot of lessons from the CBOs on ways to improve implementation of this project. They had very clear strategies for feeding back to us misinformation and disinformation on what they were hearing and where it was coming from. They suggested crowd canvassing events, so at churches, health fairs, swap meets, in addition to the door-to-door work, and use of mass texting to make people aware of these pop-up events. They also had creative strategies for engagement. They would have in the Central Valley, they had a vaccine-ready ambulance with nursing students who would, if someone said, I want to register for the vaccine, rather than just signing them up, they would actually provide them with the vaccine and then send them and then wait 15 minutes and check on them. I think the other thing that was so important was the lived experience of the canvassers. They were from the community. Some of them were very young as 16, and some of them were older people who knew the communities and understood the types of questions that were likely to come up, understood the circumstances. And I think one thing that we learned is that the impact of COVID on these communities is just devastating. In Esperanza, among Esperanza's 15 canvassers, for example, they lost 58 family members to COVID. 207 family members and friends were diagnosed with COVID, and 75 family members lost jobs. And I want to, I think, next, see if you can,
I'm a community health promoter for Esperanza Community Housing, directing the health programs of the organization. I personally wants to get involved on this campaign because I lost 11 family members from COVID. And Esperanza is committed, as organization, Esperanza is committed to give information and provide resources to the community. We are serving this South Los Angeles for more than 30 years. South Los Angeles believe on us. South Los Angeles trust promotores from Esperanza, and we have the obligation and the law to help them. able to make an appointment to be able to help somebody's a success story. And we can start like to see the percentage of people getting vaccinated in our zip code. We start with 33%, and now we are 75% vaccinated, and 90006 and 73% vaccinated on city of Paramount. I think that is the biggest success that we can tell you. But stories like a little older lady, 90 years plus, waiting for somebody to knock her door because she was not able to walk. And one of my canvassers give the opportunity to bring a transportation for her. That's a success story. One of homeless people waiting because it's diabetes, no legs. Nobody was asking her for the opportunity to get vaccinated. One of my canvassers make the appointment, doing everything possible to get that person to get vaccinated. We have tons and tons of success stories, but this campaign not only help Esperanza to save lives in the community, when this job opportunity for our own community, for our promoters, for our neighbors, they help to save, to don't become a homeless. I hear a lot of stories from my promoters, from my team. Then, thanks God, they have this job opportunity. They are able to pay the rent, even though it's temporarily, was so helpful. And we are more than grateful to have this opportunity. My canvassers, my team, they were to the laundries, outside the churches, sometimes outside the schools and get in trouble. And I think they are working so hard to make sure everybody has the opportunity to get this vaccine available to them. They are doing everything in their hands to make this possible.
So that was an example of, I think, some of the impact of this type of work in many of the communities across LA County. I just want to highlight that, there were, all told, as of last month, there were 1.6 million doors canvassed, more than 500,000 phone calls, 1.2 million text messages, more than 100,000 conversations at different events, and about 40,000 individuals registered for the vaccine. I think the other thing that we tried to do is ensure that there's research and evaluation of these processes to understand what works and what doesn't. We did surveys. We're currently doing surveys that are being led by one of our junior faculty, Lisa Mansfield. Actually, she's a fellow, Lisa Mansfield. Surveys with the canvassers. We're doing secondary data analyses, including geographic analyses, and really trying to understand the impact of social determinants, food insecurity, rental relief, employment assistance, et cetera. And then finally, investigator development and support. So junior faculty, fellows, graduate students, and undergraduates are all working on the project. I'm going to end with sort of thinking about ways to address COVID-19 misinformation, reduce disparities, and reach underrepresented communities. And you can replace COVID-19 with diabetes, hypertension, stroke, asthma, preterm birth, you name it. I think these strategies are fundamental and really critical. So addressing those challenges directly, giving it appropriate time and appropriate funding to these types of efforts. The paradigm shift, we've been calling it the Keith Norris mantra, going from hard to reach to hardly reached, and making sure that we actually act on that and try to do everything we can to reach the people who need these resources the most. Listening to and learning from the community, both about what they're hearing and where they're hearing it from. Sharing what we know and what we don't know, and recognize our own biases, the implicit bias that affects our ability to engage effectively with communities. Thinking about non-traditional outreach strategies that address needs while providing accurate information, and partnering with experts in the academic realm and in the community. You know, we can work with existing centers that work with underserved communities, minority serving institutions, CTSAs, RCMARs, and partnering with the community, the CBOs and individuals who have deep knowledge and understanding, those who are trusted within the community. So thank you for your time. I think I went over, so I brought you back to, I did it on purpose to bring you back to the correct time frame, Carol. I'm happy to take any questions.
Thank you, Arleen. That was amazing. And I know in the chat, some people would love your slides, and I think we can make them available on the CHIME website along with the rest of the meeting materials. We actually are still ahead, Arleen. We started you early.
Despite my best efforts.
Yeah, despite your best efforts. And we have 20 minutes before the break. So, you know, I just want to first congratulate you. And, you know, I don't know when you sleep actually, but you know, the impact that you've had in our state and our city, you've pushed the envelope in terms of partnered research to a level that I think we could not have even have dreamed was imaginable when you became a RCMAR scholar. So I just want to congratulate you on the work, but I also want to open the floor for comments and questions from other folks on the call.
And I do want to say, yes, half was definitely part of our list. I'll go back and make sure that you guys are on there, because it was wonderful having Felica and her amazing team be part of the canvassing group. So I'll make sure we change that if it's not there, but I thought you guys were there.
Oh, thank you so much. It was excellent. And I got a lot of quotes from our canvassers that we captured to just talk about their experience in the field, because they really talked about a cadre of issues, but also the support that they felt, and they're able to change people's minds in the field about the vaccine. So it was really, really interesting on their take in the community. So, and Juanita's on too. She was the coordinator for the canvassers in the field.
Yes, great.
Thank you for the opportunity.
Well, this is Susie Shapiro, and I just wanted to say, excellent job. You touched on so many of all the thoughts that I always have when we talk about, you know, reaching out to the communities. And interestingly, I kind of correlated that a lot of the things that I had been watching on the evening news about, you know, the impact that's happening and what attempts are being done and all that sort of thing, to be able to now correlate them right back to this kind of a project where it was you guys that were behind so much of it. So congratulations, and from the community, thank you for the work you've done.
No, thank you so much, Susie. You know, I think there's so many people doing this work across the country, and we're learning from them. We're sharing best practices. And so I think this is a model for how we can work for so many conditions.
Other questions or comments, please?
This is Juanita.
Hi, Juanita.
Hello, everyone. Yes, as the CBO manager for HAP, working on this project, I know that that generation that's between the age of 30 to 40, we still have a lot of work to do, because they are educated. Many of them are educating themselves and looking at things, but they are fighting hard, many of them, in regards to their reasoning for why not wanting to get the vaccine, you know, and having a group of them telling me the only shot that they was gonna have was the Patron or the whatever the alcohol shot is. That's the only shot they're gonna see themselves getting. And so I'm like, oh my, and because I mean, that group, we still have to have a lot of conversation with that age range. And I've been noticing that we've been having that population have a certain significant amount of deaths in that population. And that has also been causing anger and mistrust too, because they're watching their friends and loved ones at that age range go it could be non-responsive, go into the hospital system, and the hospital send them home with COVID and pneumonia, and they die. And they're like, okay, so what? They sending us home to die now, and stuff like that. And so it's been a hard conversation for myself and some others with that generation, you know.
And Juanita, you're so right. You can't underestimate the work that the canvassers have to do when they are out in the community, because they hear these stories. And, you know, I think one of there's a lot of science here too of, you know, detailing and counter detailing and motivational interviewing, and sometimes just listening, right? Listening and letting people talk about the concerns they have. And it may not be that first conversation. You may have to go back 2, 3, 4 times. They may have to hear it from a number of different people. But sometimes people, after hearing this, after being affected personally, after having family members who they've lost, they sometimes say, okay, it's time for me to do this. And it's hard to know when that is for some communities, but you're absolutely right. In that 30 to 40 year age group, we're seeing just this intransigence, but we're also seeing people sort of change their minds. And it's the work that you and the team at HAF and so many of the other canvassers are doing that has made the difference.
So Arleen, there are some questions in the chat. I would like to call on Kathleen. Why don't you ask your question out loud?
Sure. Hi, Arleen. It's Kathleen Sanchez, one of your RCMAR colleagues.
Yeah, alumni colleagues. Yeah.
Wonderful to hear from you, Kathleen.
Yeah, thank you all for doing this and for sharing this wonderful presentation. So Arleen, I was just wondering if you could just share your ideas off the top of your head about how these lessons and strategies can be institutionalized into large organizations like the Department of Public Health.
Yeah, I think that's a great question. And I will tell you, the public health department has been at the table. You know, they're facing a whole different set of constraints and barriers. But I will, you know, one of the projects we're working on with the public health department in LA County and with LA Care is providing vaccine to homebound individuals and really helping to identify them in part through these canvassing efforts and really streamlining the process of getting vaccine out to people who sometimes they're reluctant to get it, but you know, if you can't reach them, you'll never be able to talk to them about the potential benefits of the vaccine. And then there are people who are fine, want to get it, but have had a hard time. The other group that we've worked with is the State Department of Public Health, and they have asked for our materials. We've shared materials with them, they've shared materials with us. And I think it's that sense of collaboration. At the state level, they're particularly interested in diversity, equity, and so they're really trying to build that out. And so I think I'm hoping this collaboration will have long-reaching effects at the state level. But I think it's really sort of having the community at the table and not having this be one directional. It shouldn't be the state has a mandate, we're going to do this. You've really got to have listening sessions. You've got to have patient and family advisory groups, which they have in DHS, but they're stronger in some areas than in others. How do you engage patients, family members, the community at large around these questions? It takes time, it takes work. And you have to have the experts who are often not people in any of our academic institutions right now. And so you need to build out that cadre of, like the community faculty at CDU, build people, make sure that folks have the information they need. You know, when you think about on the margin, what it took to get the CCP up and running, you know, we can quantify that. You know, you can say, this is how much it will cost to do this. And so really think about what's the cost benefit ratio. How high is that for projects like this? We need to show the effectiveness of these methods in terms that both bean counters and, you know, public health folks, business people understand, because the implications of, you know, these types of efforts are huge for recovery, and I think we're also shifting now from, a focus on the pandemic, though we have to always keep our eye on that, to really how do we build out a system of recovery for the highest risk, most vulnerable communities across our county and across the state and the country.
All right.
Good morning. Good morning, everyone. This is Ms. Placida Williams from Charles R. Drew University. Arleen, that was wonderful presentation. Wonderful.
Thank you, Ms. Plus.
I just want to say thank you for mentioning community faculty at Charles Drew. I just spoke to someone the other day from my church, and she says, Plus, I'm just waiting for evidence. And I said, evidence? She said, someone has to convince me to get the shot. I could not believe she said that. She said, I'm just waiting for, I said, what more evidence? People are dying. And so I told her about my son-in-law. He had COVID at the end of November, beginning of December. And my daughter said, I'm not leaving my husband. I was petrified. I said, oh my God. I put on everybody's prayer list I could think of, them. And so, again, we need community people at the table to tell the truth. There's people on this call that don't want people to know. They are afraid to get the shot. They don't want to tell anybody because we have academics that are afraid. I called an emergency medicine doctor that we work with, and I called a doctor at Charles Drew, and I said, you got to talk to my daughter. My daughter said she's not leaving her husband. She's going to stick with him. He knew he was sick, but he kept working because his business is to pick up deceased bodies. He kept working, and the doctor at Drew told her, don't let him come home. He already came home. She took him to the hospital, and short story, I'm going to make it short. And they said, let him off at the curb. I called you, Arleen, and I called Dr. Norris, and they said, you can't come in. They kept him for a couple of hours. They sent him home. And the doctor at Drew said he's got to go back because he was so sick. They took him back. They kept him for 4 days. His oxygen level was at 3 or something like that. And we thought he was going to lose him. And he couldn't walk. He couldn't do anything. Anyway, the bottom line is we have to tell the stories of what's going on with us. And this is a serious illness. I mean, the emergency medicine doctor, he and his wife both work in the emergency room. They've never seen anything like this. And so we have to tell our own personal stories if we have them. And like the lady that just spoke, we have to tell the story of what's happening. It's not from an academic perspective. It's a life perspective of what's going on because people are dying. This is not a flu shot. This is not a whatever. This is not this is life experiences. And so I'm telling people on this call, if you know that something is going on, tell what's really going on. This is serious out here. So
you are absolutely right. Plus,
I'm serious. This is a serious. I know this is not just about the COVID, but and now we got another variants going on, and like Fauci said, we don't know what's going on. But
I think it's getting your story out there. Plus, it's making sure that people understand that people who look like me can get this or can get the vaccine, and explain your thinking. Because I think that resonates with folks. I see that Aziza has her hand raised.
Yeah, I actually, I'm going to try to go in order. And so
sorry.
Dr. Amani put something in the chat about 10 minutes ago. So I'm going to go to Dr. Amani and then to Aziza. So go ahead, Vita, with your question.
Thank you. I am really appreciating the discussion, and Dr. Brown, the work is tremendous, and I echo what everyone else has said. Like, thank you on behalf of so many people for your persistence and for modeling a way that we can put the ideas into action. My question is around, in terms of your reflections of, what you've been through and what you've seen happen. Are there other community engagement strategies that you would recommend or would want to be seen implemented that you haven't been able to yet?
No, that's a great question. And I think, the deliberative community engagement project that we did I think a lot, when we first started it, we thought this is just huge. I don't know, it will require so much time, so much money. We don't know if this is even feasible, much less sustainable or translatable and generalizable to other conditions. But I think as we've been thinking about it, there are actually so many ways to use sort of brief strategies, whether they be, consults, or they call them, these little consultations with community members who provide input on one topic, or having a more sustained approach. And so I think we're trying to see if there's a way for us to do this. I think I mentioned in my little asterisk with hypertension, with a project that was funded to address health disparities around hypertension in the LA County Department of Health Services. So we're trying to do it with patients in the community clinics, in the primary care clinics, but also patients in the specialty clinics. So I think, can you bring the community to the table, even when they aren't necessarily the patients in a health system, but who can say, in my community, this type of approach isn't acceptable, and here's why. Or if you're gonna try to do this, here's what you need to think about. And some of it is community specific, and some of it's just being a human being, and that was the thing that struck me about what we learned here, is that so many people said time and again, just treat me with respect, welcome me, help me understand what this is all about. And so I think we, as clinicians, as educators, as investigators, have to figure out ways to explain what we're doing in a way that's both understandable and acceptable, but also promotes healthy debate and discussion. It's very easy for people to become polarized and worry and just either shut down because, they'll never understand. They just think I'm an idiot. But we need to think about ways to really share our knowledge and our understanding, and make sure we hear other people's knowledge and understanding of the situation, or else we're just going to end up in the same situation that sort of got us to these crazy COVID times.
So Asisa, you got the next question.
Yeah, thank you. So this is actually to underscore what Ms. Plus just spoke about in creating and producing these town halls, particularly the Sabbath town halls, but town halls in general. What we've done is to reimagine who the content experts are and what categories they come from, and not just academia, or not just researchers, and not just service practitioners, but we began to bring in folk like Mr. Patrick, who is a worker in decedent services. And so he had the unpleasant job of picking up bodies who were primarily had died from COVID. And when he spoke at our Sabbath town hall, he had been doing this now for going on 2 years. He broke down and cried for the first time, and he said and begged people to get the shot. I can't believe that there's nothing that would make me believe that didn't change somebody's mind and heart, particularly those who are claiming that it's a hoax and that it doesn't exist. This man talked about the numbers of people that he has had to pick up. I also brought in someone who worked at a funeral home at one of the town halls, and then at another brought in somebody who handled decedent services at the VA. So when we consider just regular folk, but who have the very unpleasant job of having to go that deep, I think it just begins to, again, add to the pool of content experts that we need to consider when we want to have convenings.
Mm-hmm. And I just want to comment on Aziza's Sabbath town halls that she did in collaboration with just a really dynamic group. And one of the things, I felt really honored to have been invited to be part of it. And, there were several academic members of the team, but there were also a lot of people, as Aziza mentioned, who were just in the trenches and who shared such important information that had policy relevance, right? So that, people in decedent affairs weren't considered frontline workers at one point, and just understanding who was really at risk and who was truly frontline was so important. And it was something that we could convey to state policymakers, to others. So it's important for us to make sure that those voices are at the table, and that groups like yours, Aziza, can really help us to make sure that we have adequate representation.
All right, I'm gonna, I'm always torn when there are more people who want to ask questions, and I'm sure Arleen's going to be around, but I also know that on Zoom people really need their breaks. And so I'm going to close the questions and just, Dr. Jones had to leave the meeting just a minute ago, and she typed into the chat, fantastic work, Dr. Brown. Congratulations to you, Dr. Norris, and the community partners for doing this excellent work. Thank you for bringing forward the issues that matter the most to community members and other stakeholders. So with that, Felica, please accept my apology, but I'm going to have us go to break because we all need to be back right at 11:15 sharp so that we can stay on schedule. So thank you.
Thank you all.